Hoosiers families recover from this crisis. We'll ensure that those dollars not only provide necessary evidence-based services for Hoosiers, but Hoosiers currently suffering from a substance use disorder, but will also fund new and existing prevention efforts aimed at addressing this disease at its root. Now, I'd like to introduce to you someone who has been directly benefited from the programs that have been put in place by people in this meeting. Christy Crowder is director of the Wabash Recovery Center in Terre Haute and one of our 14 regional recovery hubs. We've asked Christy to share the story of recovery with you, and she's going to use her own experiences to give back to a community that gave her so much. Christy?
Thank you, and I really appreciate you guys asking me to be on here today and speak. My name is Christy Crowder. As Mr. Hunsinger said, I'm the director of the Wabash Valley Recovery Center in Terre Haute, Indiana. I'm also a person in long-term recovery from substance use disorder. And just to tell you a little bit about my story, I grew up in a small rural community in Indiana, Fountain County, if anyone knows where that is. I came from a great family. My parents were married. They were business owners. They owned a restaurant when I was growing up. I had several family members. I had 3 aunts who were attorneys. I had one who was a judge. I had a lot of great role models in my family. What I didn't realize growing up was that there was also a lot of substance use and mental health history in my family. And, this really wasn't talked about in my family. And I'm not, in no way blaming my family or my parents. They thought that they were doing what was best for me at the time. But I talk about that to illustrate, a couple of points when we talk about prevention. Being honest about family history and talking about family history of substance use and mental health is so important to talk about to our children, and especially at a young age. I didn't know that, my mom, suffered from depression. She was treated for it. And so she functioned really well. I didn't know that my dad, had a history of alcoholism, before I was born. And so those factors, really played in, when I became a teenager, and I was definitely a rebellious teenager and started experimenting with a few things. How quickly I became addicted, had so much to do with that, that genetic component of addiction that ran in my family. And I had no idea that was going to cost me the next 20 years of my life, battling substance use disorder. And so, I started pretty early age, about 14, with marijuana, alcohol, things like that. Escalated pretty quickly to cocaine and methamphetamine as a young teenager. Started a little bit with the opiates at that point in time. When I was 22, I became pregnant with my son, and I was able at that point to kind of put everything down for a little while. I got married. I was raising my son. I went and graduated from nursing school, was living a pretty good life. And then it was around 2006. I was in a car accident. And that was around the time where, opiates were pretty widely prescribed. Some opiates for several months because of the injuries related to the car accident. And then because of that, addictive nature that I have, that so many of us have, I quickly became dependent on those. And when, the doctor stopped prescribing them, I quickly found other ways to acquire those kind of drugs. That went on for about 4 years. I was heavily addicted to, narcotic pain medication, but was able to hide that from my family. I finally was able to reach out and ask for help. I tried a couple of different treatment centers. Nothing worked at that time. Eventually I ended up getting a divorce from my husband, losing custody of my children. They went to their, between their father and between family members. I lost my job. I had lost my nursing license, due to my addiction. Of course, it became out of control. Ended up moving on to IV heroin use. Became homeless, became, a person out there doing anything and everything that I could to get that drug. Eventually that led to, a string of arrests, theft, stealing, in order to get money for drugs. But, I didn't realize it at the time, but I'm very grateful now for those arrests. I believe that the criminal justice system saved my life during that time. After a few arrests, I was facing about 26 years in prison. My lawyer came to me and offered me something called drug court. I didn't really know much about it at the time, and I really didn't have much confidence in myself to be able to complete that program. I'd already spent about 9 months incarcerated. And so the agreement was for me to complete 2 years of drug court, and that could, prevent me from having to go to prison and spend time in DOC if I was able to complete that. So that's what I did. I did have some struggles in the beginning, but what I found out through that drug court program was that the judges and the case managers and the probation officers who were involved in that really did actually, care about their people who were involved in that program and wanted to see us succeed, wanted to see us get our lives back. They didn't want to send us to prison. They wanted us to get treatment and wanted us to get help. And so, I'm eternally grateful to those people in that drug court program and to that judge. I was finally able to, complete that drug court program. It's now been going on 5 years that I've been in recovery from substance use disorder. I was able to actually get my nursing license back, go back to school to become a licensed addictions counselor. Of course, regain custody of my children. I own my own home. I love my job, and I get to work every day, giving back to, and helping people who are in the same situation that I was in when I was so, hopeless and thought, I just thought that I was going to die in my addiction. And, I thank Jesus every day that I'm still here. I went through the Next Step program in Terre Haute, which is a wonderful program. I just have to give a shout out to them. And now, as the director of the Wabash Valley Recovery Center, we are one of the anchor organizations for the Regional Recovery Hub, which is that was such a blessing that we got, when COVID hit back in March, to be able to be a part of that, and to be able to provide services to our region of the state in Indiana. We do all, peer-based recovery support services, which I think is such an important component, in the continuum of care for substance use disorder. And I guess that's it. That's all I have. Thank you.
Well, thank you, Christy, and really appreciate you sharing your story. And I've been to Next Step, and Dana and her team do such an incredible job. And we'll look forward to post-pandemic coming down and visiting the Recovery Hub and seeing all the great work that you're doing there. Your story really is a reminder that in order to overcome the toll that COVID-19 is taking on our communities, we must ensure that individuals have equal access to the full continuum of care, and that we have as many intervention points in the system as possible, so that at whatever time that they're ready to receive treatment, that we can provide that at that point. If you recall, back in May, we announced a $1 million partnership with Overdose Lifeline to fund and distribute 25,000 doses of naloxone. And through this collaboration, I'm proud to report that Overdose Lifeline has already distributed more than 22,000 doses, and that's just in 8 months. It's also in addition to the work that Dr. Box and her team do to distribute 25,000 doses through our local health department statewide. So I'm pleased to announce today that we are again partnering with Justin Phillips and her team at Overdose Lifeline, this time to fund and distribute 215 Nalox box units statewide. A Nalox box is a hard acrylic box mounted to an exterior wall that provides 24/7 access to naloxone. And in just a moment, Overdose Lifeline Director Justin Phillips will walk us through what's inside each box and what it means to communities across the state. Any business or community entity committed to helping Hoosiers at risk of an opioid overdose is eligible to request a Nalox box unit. The goal is to place at least one in all 92 counties. Now Justin will share more on who's eligible to receive a unit and how to request a unit from their community. Justin?
Good afternoon, members of the commission, and thank you, Mr. Hunsinger and Governor Holcomb and Secretary Wathall for continuing to support the saving lives of individuals with access to the overdose reversal drug naloxone. Overdose Lifeline is so grateful to be able to play a small role in this effort. So as Mr. Hunsinger already mentioned, we have distributed over 22,000 individual doses of naloxone across the state. We can't do that without our grassroots community partners. We have 37 separate distribution entities in 92 counties across the state, and they are the ones doing the work daily on the local level. And already, to date, we have 35 individuals and organizations committed to placing a Nalox box in their community and monitoring it on a daily basis to ensure that the naloxone kits are still there and available. And so access to a Nalox box is really going to increase the ability for an individual to gain access to this life-saving drug. This Nalox box is going to be available 24 hours, 7 days a week. It looks like this. Can you see? No, because the stupid virtual background. Hold on. We can fix this technology. There. Now you can see, even though there's a glare. So it's a very hard acrylic box, as Doug mentioned, and it has a closure, but it won't be locked. And inside each box will be approximately 6 to 8 individual doses of naloxone with instructions on use and referrals to treatment as required under the law. We prefer these boxes be mounted outside, potentially with some cover because of the elements that do exist outdoors in Indiana weather, but accessible to individuals 24 hours, 7 days a week, so outside. If I could just share my screen briefly, I want to show you a map. On our website, individuals will be able to pull up this map, which will indicate where Nalox boxes are located within each area of the state. You can see that we already have some dots. These are the ones that are not confirmed completely, but that will exist. The picture that you see is an actual site that does exist at 1100 West 42nd Street. And what we hope to do is have a photograph for each Nalox box showing you where on the building you can find that box so that you're not struggling to locate the box in the event of an emergency. Individuals interested in putting in a Nalox box in their community can send an email to me at justin@overdoselifeline.org or call our 800 number, which is 844-554-8454. And I'm happy to answer any questions. And thank you again so much for the opportunity to contribute to saving lives.
Well, thank you, Justin. Are there any questions for Justin? Well, great. We'll thank you, and we'll be putting out more information. We'll have information on the Next Level Recovery website as well regarding contact information to request a Nalox box. And I think it's also important to note that this was a collaboration through Division of Mental Health and Addiction, Overdose Lifeline, and is being funded by the State Opioid Response Grant. Next, it's my pleasure to introduce a woman who's become a household name, who probably needs no introduction, but Dr. Christina Box is the Indiana Department of Health Commissioner, and she's graciously taken time out of her busy schedule to present the latest maternal mortality report released in December. Dr. Box.
Thank you, Executive Director Hunsinger. I really, really appreciate this opportunity. I think it'll become clear why I'm reporting to you about maternal mortality as we move further along. Next slide, please. So this was the first time Indiana had ever done a comprehensive maternal mortality review. We did it for 2018. Many of you know that infant mortality is considered to be kind of a window into the health of a state, as is maternal mortality when we look at it. We had legislation in 2018 based on really an article that came out in the USA Today saying that Indiana had the third highest maternal mortality rate in the nation. So our legislators got behind it and basically voted for us to have a maternal mortality review committee and the ability for us to be able to review the records and do that. Then we went out and got a CDC grant for it to the tune of about $2 million over the next 5 years. So that really set us up very well to be able to look at maternal mortality in the state of Indiana. The goal behind this, obviously, is to review every single pregnancy-associated death in the state, to understand the causes that surrounded that death and identify those factors that might be modifiable so that we could provide recommendations going forward in the future that we might be able to change that potential death in the future. Next slide. Our Maternal Mortality Review Committee, we probably had 2 to 3 times the numbers that you see here that volunteered for this committee from all over the state. We were careful to geographically represent the entire state, both urban and rural and all parts of the state. We have all the different individuals that you can see here that were engaged. The maternal fetal medicine specialist, Dr. Mary Pell Abernathy, actually ran this committee. She was at that time the president of the American College of the Indiana American College of OBGYN division. And also a big part of her practice is substance use disorder, which turned out to be a really good thing. As we got further into evaluating these cases, we realized that we needed to add more individuals with specialties in substance use disorder. So we added an MSW licensed social worker who works in substance use disorder. We added an MSW in safe systems direction, the director at DCS. We added Captain Kevin Hunter in Fort Wayne, who, as you probably all know, has been a huge support across the state for viewing substance use disorder as a disease and not as a failure. And we will be adding another mental health LSW with this next review, now starting into 2019. Next slide, please. It's important to know the way we used to look at things. We used to look at death certificates that had, all our death certificates have a checkbox where the provider who certified the death would check whether that individual was pregnant at the time of her death or in that year prior to her death. In that year after that she was pregnant. When we looked at that, when our abstractors pulled that, what we call NVSS data, so the National Vital Systems data, and this is what that USA Today report was based on. When we pulled that data, we found about 60 women. Careful review and medical extraction over all those medical records, the coroner's reports, autopsies, and speaking with our certifiers. We actually called providers that certified the deaths. We found out that of those 60 women, 27 of those women were not pregnant at the time of death, nor were they pregnant within a year of their death. So we kind of got down to 33 individuals. We had mandated that hospital systems and clinics, if they were aware of a maternal death, that they reported them. So we added 2 deaths from that. So you can see the far right box on the top line there. We got up to about 35. We then decided we could be missing additional maternal deaths. So what we did was we pulled every death certificate on every woman aged 10 to 60, and we crossed that with birth certificates and with fetal death certificates. And we found an additional 28 deaths that would never have been looked at, for a total of 63 pregnancy-associated deaths. Next slide, please. Now the difference, it's important to delineate the difference between a pregnancy-associated death and a pregnancy-related death. The pregnancy-related death really is a subset of the first. A pregnancy-associated death is the death of a woman during her pregnancy or within a year of the end of that pregnancy, regardless of the cause. So this could be a motor vehicle accident, it could be an overdose, it could have been trauma of some kind, maybe, a violent trauma. A pregnancy-related death really refers to a particular exacerbation of an underlying condition that woman may have had. So maybe she was a severe diabetic, or she had lupus, and she had borderline renal failure, and now all of a sudden she went into renal failure because of the pregnancy and unfortunately passed away. Or it could be a condition that started de novo because of the pregnancy. The most common one of those would probably be the fact that the individual actually had a clot, developed a blood clot because of her pregnancy that went to her lungs and was a pulmonary embolism. Next slide, please. Excuse me. So the MMRC, or the Maternal Mortality Review Committee, found that out of the 63 pregnancy-associated deaths, 10 of those were truly what we call pregnancy-related deaths. And you can see the pregnancy-associated and pregnancy-related mortality ratios here being 77 per 100,000 live births, or 12 per 100,000 live births. You can't compare these ratios with other states, unfortunately, or with the CDC's general NVSS data, because as you can see, our data was so off, and I'm sure other states are also. They now have 44 states that are doing in-depth reviews of their maternal mortality, as Indiana is doing. They are trying to standardize the way we do that by using the same, what we call Maria forms, to report deaths and the contributing factors. Eventually, I think the CDC will be able to compare some ratios across the United States, but for right now, these are not good things to compare, because some people even do maternal mortality just if you died within 42 days of the end of pregnancy. And we find that many African American women, unfortunately, have more complications with their heart, like cardiomyopathy, and those frequently don't show up till later. Next slide, please. The Maternal Mortality Review Committee actually found that out of the 63 pregnancy-associated maternal deaths, 10 of those were pregnancy-related, as I mentioned, and that was really in 2018. Maternal mortality, as you can see, like our infant mortality, has significant racial disparities. Our Black maternal deaths were 20% higher than our white maternal deaths, and this has been a consistent finding not only in Indiana, but also in other states across the United States. Next slide, please. When we looked at causes of our pregnancy-associated deaths, this is why I'm talking to you today. We listed here the top causes of death on our death certificates of any pregnancy-associated death. As you can see, accidental overdose was overwhelmingly the leading cause of death, accounting for almost 37% of our pregnancy-associated deaths. And if you looked at it, almost 50% of our women had a contributing factor of some type of substance use disorder. Also among the top causes of death were other injury-related causes like motor vehicle accidents, suicide, and homicide. So about 60% of our pregnancy-associated deaths were either from accidental or intentional harm. Also, cancer of various organs was about 9.5%, and then those acute causes of death like sepsis and other infections also occurred. When you look at I think I muted myself, I apologize. When you look at our pregnancy-related deaths, they were kind of all over the board, just kind of one-offs, but we had 2 from hemorrhage and 2 from preeclampsia, which is a disease of severe hypertension frequently in women, and 1 postpartum cardiomyopathy, which is the heart failure that people get, and 1 from a stroke. Next slide, please. So we then look at all of the deaths to determine whether there was any potential cause or particular modifiable factor that, if changed, could have prevented that maternal death. And their CDC's definition of a preventable death is if at least there was some chance of the death being averted by 1 or more reasonable changes to factors that are associated with the patient or the patient's family, the provider or the facility where the patient delivered and was cared for, or the community. Our Maternal Mortality Review Committee found 170 unique contributing factors and made recommendations for each one of these particular contributing factors. The MMRC then organized these into categories for the state, and this report will serve as a baseline going forward as we address this in future years. Next slide, please. So we basically, with our recommendations, recommended that there's a need for a coordinated team-based approach to treat the whole patient. Surprise, surprise, right? This is what we found in every significant public health issue, that you can address the clinical part of the disease, but if you don't address those other socioeconomic factors that contribute to an individual's inability to access care or continue care, to have housing, to have food, to be able to have transportation, you are not going to truly address the issues and the problems. And there really needed to be a better warm handoff between clinicians and service providers for other things like mental health and substance use disorder. They also recommended that we do the AIM bundle for substance use disorder and pregnancy. And really, AIM bundles is the Alliance for Innovation in Maternal Health, which we became a member of about 2 years ago. And that is an American College of OBGYN HRSA supported program that really institutes safety bundles in hospitals across the state to address the most common causes of infant and maternal mortality, mostly maternal mortality. So we've already done the hemorrhage bundle across the state of Indiana. We just rolled out the hypertension bundle. And so our next one will definitely be working on substance use disorder going forward. The other recommendation, which I'm very anxious for you to hear from Dr. Rosiniak later in the program, is extended postpartum coverage for Medicaid patients to ensure that they have proper access to care for chronic conditions, oftentimes substance use disorder and mental health disorders beyond that 60 days postpartum, because we know that highest risk time is when a mom gets home and is stressed, has that new baby, potentially her other children, and still needs to have support going forward. They also recommended further professional training to make sure that all of our providers across the state and our hospital systems across the state have training in implicit bias and trauma-informed care so that we could decrease that stigmatizing communication methods that are frequently used, especially with women who are pregnant and have substance use disorder. And the programs that have been most successful around our state have really been able to conquer that and really made women feel accepted and a part of the team across the state of Indiana. We also recognize the need for having improved connectivity through home visitation programs. And so I'll talk a little bit about the OB Navigator program and how we're doing that already with pregnant and postpartum women. And then that importance of seamless transition from the inpatient treatment facility to outpatient recovery services was noted as an important factor. We still need to continue obstetrical substance use disorder providers or pairing obstetrical providers with substance use disorder providers across the state. And that could be in the form of an advanced practice nurse, a physician's assistant, or other individuals. Next slide, please. I just want to mention a few of the existing programs that I believe will impact our maternal mortality rate also. Obviously, you guys know a lot about our OB Navigator program. It's now known as My Healthy Baby because that resonates better as we've done some focus group studies. And this program was basically just set up, well, I'll talk a little bit more, but you can see the list right here. Let's go to the next slide. Was set up to make sure that what we did was we looked at our highest risk counties for infant mortality, and we looked to women who were covered by Medicaid and offered them the opportunity by reaching out to them to be connected to a home visitor, whether that was a nurse from Nurse Family Partnerships, whether that was somebody from DCS's program Healthy Families, whether that was a community health worker. There are a lot of different programs out there that we've been able to kind of organize in these counties across the state to make sure that women have support not only through their pregnancy, but through that first year of the baby's lives. We did roll out to 22 counties in 2020, and we'll roll out to an additional 25 here in 2021. The good news is that our data is showing that we have a large percentage of our African-American women who are accepting referrals, even compared to our white women. So we do believe that we are reaching the population that is really accounting for a higher incidence in infant mortality. And as you can see now in our maternal mortality. Next slide, please. So that we also have an Indiana Perinatal Quality Improvement Collaborative, which is a lot of volunteers, again, from the state that works closely with the State Department of Health. And really what we have set up is a perinatal substance use disorder program And 60 of our 83 delivering hospitals are actively involved in screening women if they haven't been screened prior to it when they present to the hospital for substance use disorder, both verbally and toxicology-wise if indicated. We also have offered pharmacologic and non-pharmacologic treatment, not only for mom, but for baby also, and careful discharge planning for mother and infant. The VAUGHN membership is basically just it's called the Vermont Oxford system. And basically what that is just educational modules that we bought that we can share not only with our hospital systems, but our providers. We've shared it with First Steps. We're going to share it with all of our community-based home health workers and home visiting programs so that we can continue to educate and get everybody kind of on the same page about what this population needs as far as support going forward. Next slide, please. So we also, obviously, when you work on here they are at delivery, we had to go forward and look at these women when they first present in the emergency room or whether that was in my office as an obstetrician. And so House Enrollment Act 1007 helped with that in 2019 when it basically became state law that every provider that offers obstetrical care has to do a validated verbal screen for substance use disorder, and then either treat that patient or refer them for treatment. And we developed a bundle, of kind of a practice bundle to help in the prenatal care setting for this. We've got an algorithm and a checklist and screening tools, and then have identified substance use disorder resources for practitioners across the state. And I would say that it's really important that we have, next slide, partnered with FSSA and DCS on all of this. There's been a joint effort across the state with FSSA, Department of Health, and DCS to make sure that we're doing a really good job on plans of safe care. So when that mom kind of leaves that weekly visit that they were having with their obstetrical provider, and they're out to living back at home or living with family, how do we continue to make sure that that mom and baby are both still safe? And so we have worked through American State and Territorial Health officers on a program, and through SAMHSA to develop this program for the state of Indiana. And basically, it just kind of tries to bring everything together so that this family gets follow-up with home visitation and wraparound services. I'm really the last one there, excited for you guys to hear from Dr. Rusiniak about the Mommy Project that we will be seeing rolled out here in the state of Indiana, I believe, this summer. And then lastly, next slide, please. I just want to mention Community Health program. It's called CHOICE, and I love that it stands for Change, Hope, Overcome, Inspire, Compassion, and Educate. And I want to really give a shout out to Dr. Anthony Sanders and Amy Wire, who have worked so hard on this. I will say the whole concept of OB navigation and having a navigator walk through a pregnant patient through her pregnancy and that first year of life really kind of came from this program, and that need to be able to identify those socioeconomic factors that become such a barrier in so many of these women's lives to prevent them from really staying in treatment. I know you can't see this very well, but there's a big focus here on making sure that the appropriate patients that need to be admitted for detox and initiated on therapy can get that they get the behavioral health support that they need, that there is extensive inpatient and outpatient follow-up and support and community resources for these women. And then this development of an individualized care plan for each one of these families going forward, and the care coordination for social determinants of health. Next slide. So I think you guys will be excited to hear from Dr. Rusiniak and from Elizabeth Wall, who is his Mommy Grant Manager, who's an amazing person too. And I'd be happy to answer any questions that you guys might have. Thank you for your time.
Thank you, Dr. Box. Any questions? Okay. Thank you so much for the time, and I'm sure we'll probably have a few questions after Dr. Dan gets through with his presentation. But next, we'll hear from Dr. Dan Rusiniak, who is the Chief Medical Officer at the Family and Social Services Administration, to give us an overview of a new grant that they are working to implement. So I'll let you take it from here.
Thanks, Executive Director Hunsinger. I appreciate it, and thanks to everyone in attendance today. I'm going to talk a little bit about a cooperative agreement grant that we have with CMS. It's titled right now the Maternal Opioid Misuse Indiana Initiative. The CMS program is titled the Maternal Opioid Misuse Program. Well, we may do some of the same focus grouping that was done with My Healthy Baby to potentially change the name, but next slide. But I want to talk a little bit about what this program is, what it really looks to accomplish. So when I began in FSSA, it was 2018, and that correlated nicely with my background as a toxicologist in emergency medicine and with the governor's initiative, which was really to attack the drug epidemic. But I'll remind folks in that 2018 agenda, under that pillar also was to reduce infant mortality. So shortly after I arrived, an opportunity came out through CMS, which would pick up to 10 states to really develop a program that would get more pregnant women with opioid use disorder into sustained recovery. Next slide. So really overall, what our goal is, it's a cooperative agreement with CMS to address fragmentation in the care of pregnant and postpartum Medicaid beneficiaries with opioid use disorder. And we're doing that through state-driven transformation of the care delivery system. And ultimately, our goal is to improve the health and outcomes of moms and their infants. So that's the overall, but I'm going to go through this in a lot more detail. Next slide. So one of the things we realize with folks who have substance use disorder in pregnancy is that it is both a challenge, but it's also an opportunity. And the reason it's an opportunity is we know from some studies in the literature that women with substance use disorder, the vast majority of them, 83%, will be able to abstain during that pregnancy period from substance use. So we have a time period where people are typically motivated to get into recovery. But we also know from that and from other studies that high rate of recovery goes away pretty quickly after delivery, and that by 6 months, a lot of the women who were able to abstain from substance use are unfortunately back using substance use. So what we really wanted to look at is how do we take advantage of this perinatal period, prenatal period, and then to provide the resources and wraparound services to really get moms into sustained recovery beyond the delivery and hopefully then into permanent sustained recovery. Next slide. So as part of that, we applied for this opportunity in 2019 and we're one of 10 states that were awarded. And our state's program really looks at 4 pillars, and I'll talk more specifically about them, to get moms better services. Number 1 is to improve case management. Number 2 is provider education, and to get more providers around the state comfortable in both recognizing and treating pregnant women with opioid use disorder and in treating their offspring. To address social determinants of health through better screening and referrals, and to extend coverage. And through this, it really does require collaborations with our local communities and with our both our FSSA and our other state partners. New slide. As part of this, we had to identify the Medicaid agency as the recipient, and we had to identify who the care delivery partners are. We have chosen to partner with our 4 managed care entities. That's MHS, CareSource, MDWise, and Anthem. These are the managed care entities who provide Medicaid services to up to 80% of Hoosiers and the vast majority of pregnant women in the state of Indiana. And as such, really the goal here was to work with them really closely to how do we utilize what they bring as a way to provide better services to women. New slide. And one of the key parts of that is to really, for us, redefine and change the way we do case management and care coordination. It's sort of counterintuitive for folks to think, but really what we're looking for is at some point, you know, when a woman's in trouble, they don't usually think, let me call my insurance company, right? That's not who you call first when you're having problems. But we really want to develop the relationships with the case managers who are available 24/7 in these agencies to be that potential person that they reach out to. And so as part of this, we realized we're going to have to change the way we do case management and care coordination with our managed care entities. And so as part of that, we're really developing a comprehensive program, what we would call cooperative comprehensive case management and care coordination. It involves, number one, having biweekly meetings. So bringing in all of the case managers from the managed care entities with our MAMI team to go over how many folks are we enrolling in the program? What are the challenges and difficulties that we're having in getting them services? Where are those existing? And then through collective peer learning to help provide strategies and best practices that are working so that every case manager around the state is learning and developing more skills. In addition, we want to have the ability through these groups to monitor the progress of the program. So we'll have a variety of dashboards that will build through this, that will look at number of moms that are being enrolled, whether they're getting into appropriate mental health and appropriate addiction treatment, whether those who are on buprenorphine are still on buprenorphine at the time of the delivery, 6 months and 1 year after the delivery. New slide. Additional part of that case management is really going to be kind of addressing the whole individual. So not just their medical needs are, but what their social needs are. We know that women with substance use disorder, and frankly, all individuals with substance use disorder, often have a variety of social issues and needs as well. So as part of that, we'll be doing periodic screenings to really assess what are the additional social needs. It's not enough just to say, let's get you to your doctor, but we need to make sure that you have the ability to get to your doctor, and that may involve transportation. We want to make sure that you have a safe place to go after you visited your healthcare provider, so that might involve helping them with housing. We need to make sure that they have an adequate food and that nobody is going hungry at night, and that they have the ability to get the appropriate community and state referrals to address food insecurity. So this, in addition to, as Dr. Mox mentioned, training all those case managers and our own team on the appropriateness of understanding ACE scores and assessing them, on trauma-informed care, empathic inquiry, and understanding social inequities will be critical to this plan. So these case managers will also be providing some additional screening tools for all the enrollees as well. We'll be using a data platform called Aunt Bertha that assesses social determinants of health and then connects individuals with community partners. So if they have food insecurity, we're connecting them directly with local food pantries that can help fulfill some of that gap. And using what we call a closed loop referral system, which means we send a notice to that food pantry and the food pantry lets us know when that mom got there and subsequently picked up their food. In addition, we're working really closely with our partner programs, including the My Healthy Baby program, IPQuick, 211, DCS, the Housing Authority, and a variety of other community partners as we design this program and implement this program to make sure that we've got a lot of thoughtful input on it. Next slide. So number one is let's really work with managed care to make case management and care coordination the kind that we'd really like to see for folks who are going to have additional needs and additional challenges. In addition, we recognize that we need to improve the provider education as well. We need to have more providers in the state of Indiana, like those in the CHOICE program and those that Dr. Abernathy provide, who, number one, know how to treat women with substance use disorder who are pregnant, who are comfortable taking care of and recognizing the complications of that and taking care of their offspring. And so as part of that, we've partnered with Project ECHO and the IU School of Medicine. And as part of that, they have put together 3 tracks of peer learning that we do. And for those who don't know, ECHO is a program that initially started in New Mexico. And it was a way to try to take concentrated expertise and make sure that through a peer learning session that could be shared with providers who might not have knowledge and expertise on managing things like hepatitis C. And so IU has been doing ECHO since 2017, and we've had several partnerships with them and FSSA. So as part of this, we have 3 tracks. Number one is a track focused on providers who take care of the women. And so we've had completed 1 track already, and we'll be repeating this multiple times a year for the 5 years of this grant. And this is a 8-week series that brings in these providers and in a peer a good understanding of the issues that go into managing a pregnant woman with opioid use disorder. It's led by a lot of the experts around the state that you all have heard from in the past. In addition, we'll have an echo track that's ongoing now that's focused on the offspring, particularly for those providers who would care for infants. So to make sure that we know how to recognize neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, and that we're using best practices to reduce severity and to get moms and babies home faster. The third track that's in development right now is really focused on those case managers. And so it's not enough to tell the case managers, we want you to do a good job. We need to give them the education and the skill to do so. So we've got a whole echo track for them that's going to provide them the necessary background to know how to assess somebody with substance use disorder, to use the appropriate language, to understand the impact of ACE scores, and to utilize trauma-informed care. So we're really excited about that, and that'll be coming out later this year before we begin the program. And in addition to those case managers and managed care entities, this will be open to community health workers and home visitors as well. Next slide. The other pillar on this is, as mentioned earlier, is to extend coverage. Right now, depending on where you are as a Medicaid recipient, for those moms who the reason they get Medicaid is because they're pregnant, and that's the only reason, so they don't meet other criteria for standard Medicaid, they right now would lose coverage 60 days postpartum based on the federal requirements. But we recognize that for women who have substance use disorder and opioid use disorder who have gotten into recovery, that the need for ongoing treatment doesn't end at day 60. And in fact, we know from previous studies that a lot of folks have recidivism in that 60-day to 6-month time frame. So as part of this, we've applied for a waiver of CMS that for those moms who enrolled in this program, that we would be able to extend their Medicaid coverage to a full 12 months postpartum. Now, I will say, I would love to see this for all pregnant women in the state of Indiana, but for us right now, this is, in many ways, a pilot demonstration that will focus on this particular population, and hopefully, and as I anticipate, we'll show the benefits of this as a good way for us to sort of think about other populations that we might want to extend coverage to. So we have submitted the waiver, but we're now in the negotiation phase with CMS, so it's not approved at this time. The goal is to hopefully have this approved and ready to go by July 1st when we enroll our first mom. Next slide. In addition to this, as a cooperative agreement, CMS is closely involved and have some milestones that they are going to be monitoring us as the states on and going to be comparing us to the other states. Now, every state has its own program and their own unique aspects to it. So it'll be helpful for us as we look at how we compare to others. Number one is to make sure that we've addressed those health and social needs, that we've initiated and engaged appropriate opioid use disorder treatment, including MAT, that we have continuity of pharmacotherapy at delivery so that moms who start on buprenorphine are still, or come into the pregnancy on buprenorphine, are still on it at time of delivery. That we have appropriate postpartum care and family planning, specifically around birth spacing, to make sure that moms get the resources they need to recover from their own underlying conditions and to have some stability in their life before they start to decide and plan for their next pregnancy. And also, they're going to be tracking a patient activation measure, which really gains how involved patients are and motivated they are for change. Next slide. So overall, we've got a really large project management team. We've got a small number of folks that oversee this, myself, Elizabeth Wall, who's our program manager, and Carrie Michaels. But we have a large steering committee and a lot of other of our community stakeholders that we're engaging with as we build and implement this program. In addition, we're going to be developing dashboards that will be comparing the outcomes in these moms, comparing them across demographic, rural versus urban. Also going to be doing regional meetings, kind of what we call everyone at the table meetings, to make sure that we get everyone there to discuss what additional services moms may need, what's working and what's not working. So not just providers, but also local DCS, local law enforcement, and others that would intersect with pregnant women who have opioid use disorder. collaborations throughout our agency and across our agencies, and certainly close coordination and collaboration with the Department of Health programs, My Healthy Baby. Also with DCS, who's part of our steering committee as well, to utilize those resources and to work with them as well to get the moms the resources. Lastly, we also collaborate with the other states. As I mentioned, there's 10 states, and so we do have monthly meetings with them as well to collaborate on what's working and not working and make changes along the way. Next slide. So like I said, there's a lot of folks that are involved in this, a lot of partnership, and we are really excited to start enrolling moms. The goal right now is the first mom to be enrolled in July. I think we're building the framework by which we should be able to meet that goal. And then we have a target of getting about 700 moms enrolled in the first year. There's not a cap on the number of moms that we can enroll, but we recognize that this will likely take a little bit of time before we're kind of up and running and getting to that kind of target number. So next slide. So that's my last slide. I appreciate folks' attention and would be happy to answer any questions.
Well, thank you. Do we have any questions for Dr. Ruseniak? All right. Well, with that, thank you everyone for your time today. The initiatives that are described here are only made possible by the work that our agencies are doing collectively together. I always say that the partnership that we have across all of our state agencies is incredible, and the external partners that they all work with, we couldn't do it without that. We know when people start to feel disconnected, we must be there for them as a community to wrap our arms around them and encourage them into the path of recovery. So together with the right tools and the supports in place, we'll make Indiana a better place for all Hoosiers. I appreciate everyone's time and attention today. As a reminder, our next meeting is Thursday, May 6th at 10 a.m. and a format that is yet to be determined. So thank you for joining this afternoon. We stand adjourned.